Hypovolemic shock. Let's talk about its definition, pathophysiology, clinical features, and measurements. First of all, the definition. Critical reduction in intravascular volume, causing decreased venous return, reducing the cardiac output, tissue perfusion, cellular hypoxia, and organ dysfunction. In this, there is intravascular volume cause, which leads to decrease in the venous return to the heart, and that leads to the decrease in the output. Therefore, the blood reaching towards the tissue decreases. Let's talk about the causes of the hypovolemic shock. There are two causes, hemorrhagic and non-hemorrhagic causes. Under hemorrhagic, for example, trauma, GI bleed, ectopic pregnancy, postpartum hemorrhage, surgery, and non-hemorrhagic, vomiting, diarrhea, burns, diabetic ketoacidosis, pancreatitis, third space loss. So let's talk about the pathophysiology. As I have told earlier in the definition, volume loss is present in the hypovolemic shock due to the causes that I have enlisted in the previous slides, and there is decreased venous return which leads to decrease in the preload and decrease in the stroke volume, therefore resulting in the decrease in the cardiac output that leads to the decrease in tissue perfusion, that is, blood reaching to the tissues is decreased. Therefore, the tissues need energy, need sources to work out, and leads to lactic acidosis, and finally leads to MODS. Now, let's talk about the classification. Grading, WHO grading, class 1, 2, 3, 4. Volume loss less than 15%, 15 to 30%, 30 to 40%, and class 4 greater than 40%. Let's talk about the clinical features of the hypovolemic shock. Tachycardia, increase in the heart rate, hypotension, decrease in the blood pressure, cold clammy skin due to decreased blood pressure, as well as the extremities will be cold, delayed capillary refilling, and the tachypnea, oliguria, and the altered sensorium. Now talk about the diagnosis. How we can diagnose that person having the clinical features is a patient of hypovolemic shock. We will classify it as we all know, A, B, C, Ds. Let's elaborate this. A for airways, B for breathing, C for circulation, D for any damage, and E for any external stress. So in this airway, we check for new guidelines. It's cervical plus airway, checking for the airway, clear pathway, breathing, proper oxygen, ventilation, respiratory rate, circulation, any trauma, any hemorrhage occurring, any leakage occurring, damage to anything. And next we will do CBC, hematocrit, HB, PCV, MCV, platelet count, WBC count, ABG, arterial blood gas. We will check about the pH, PCO2 pressure, partial pressure of the CO2, as well as the oxygen and the bicarbonate levels, lactate, RFT, coagulation profile, blood grouping, CT. In all this, the hypovolemic shock, CBC, hemoglobin will be decreased, and the ESR will be increased, ABG acidosis will be seen, lactate will be increased due to the disruption of the RBCs, renal function test will be impaired, coagulation profile will be deranged, bleeding time, clotting time will be increased. Next, CT will be done for checking of the hemorrhage, that where is there leakage or anything else. For the management, airway, oxygen, two large bore IV lines, crystalloids, blood products, control bleeding, and finally treat the underlying cause due to which the hemorrhagic shock, the hypovolemic shock occurs. So the monitoring, we have to do monitoring, check for the regular BP, heart rate, partial pressure of the oxygen, urine output must be greater than 0.5 ml per kg per hour. We have to check the levels of lactate as well as the mental status of the patient. Complications can be AKI, ARDS, DIC, modes, death. Finally leads to death. Acute kidney injury, acute respiratory distress syndrome, disseminated intracoagulation, as well as the modes which finally can lead to death. So my references are from the Harrison Principles of the Internal Medicine, Davidson Principles and the Practice of the Medicine, Hutchinson Clinical Methods, and ATLS